Acute pancreatitis. It's one of those conditions that every single one of us sees in the hospital. But what if I told you the key to getting better outcomes isn't some brand new drug, but actually just avoiding a few common mistakes? Today, we're going to break down 6 really high-impact treatment errors that can make the disease worse, all based on the latest evidence. Let's jump in.
This quote from Dr. El Ramane, wow, it's the perfect place to start because it completely reframes the problem, doesn't it? It suggests that the most critical factor isn't the pancreas itself, but our own actions in those first 1 to 2 days. That puts a ton of responsibility and a huge opportunity right in our hands.
And this leads us to the central theme of this whole explainer, what I like to call the pancreatitis paradox. The very things we do to try and help can, if we're not careful, be the exact reason a patient gets sicker. It's a tough idea to swallow, but it's absolutely crucial if we want to get better at this.
So, here are the 6 pitfalls we're going to dissect today. These are the key spots where common practice just hasn't caught up with the evidence. We're talking about everything from fluids to food to follow-up. Getting these fundamentals right can literally change a patient's entire hospital course for the better.
Okay, let's start with the mistake that matters the most in those first 24 hours. Fluid management. This is a true balancing act. I mean, we know pancreatitis causes these massive fluid shifts, but the error we make goes both ways. Giving too little is a problem, for sure, but giving way too much can be just as catastrophic. This slide shows the huge shift in thinking perfectly. The old reflex, the one a lot of us were probably taught, was just to flood everybody with aggressive fluids. Big fixed volumes, 3 liters, 4 liters, whatever. But the modern, evidence-based approach is so much smarter. It's goal-directed. The goal isn't a number on an IV bag. It's a physiological response from the patient. So what does this actually look like at the bedside? Well, this framework is our guide. We start with a bolus, only if the patient is clearly hypovolemic. Then we move to a pretty moderate maintenance rate. But, and this is the most important part, look at number 3, reassess, early and often. Every 6 hours, we're checking in, looking at vitals, urine output, and labs. The magic isn't in the initial order. It's in the constant tweaking and adjusting based on how our patient is actually doing. Okay, let's move on to our next section, which covers 2 really outdated practices: keeping patients NPO for way too long, and that reflexive urge to give medications like antibiotics. This is all about breaking old habits that the evidence just doesn't back up anymore.
So, the classic question, right? To feed or not to feed? For decades, the answer was a hard no. The dogma was bowel rest. You had to let the pancreas cool down. But does the science actually support starving our patients back to health? The reality, which is backed by a ton of evidence, is that early feeding isn't just safe, it's therapeutic. I mean, look at these benefits. It reduces complications, shortens the hospital stay, and gets people home faster. You can, and you should, start a low-fat diet as soon as the patient feels up for it, usually within that first 24 to 48 hours. And please, you do not need to wait for the lipase to normalize. Nutrition is treatment.
And it's a similar story with antibiotics. It is so crucial to remember that pancreatitis is an inflammatory process, not an infectious one, in most cases. This table makes it super simple. We only use antibiotics for proven or highly suspected infection, like infected necrosis or cholangitis. Using them just in case doesn't help, and it just drives antibiotic resistance. We need to treat infection, not inflammation.
Okay, let's tackle a sensitive and really persistent myth: pain control. The pain from pancreatitis is severe, and undertreating it doesn't just cause suffering, it actually harms their recovery. But these old fears about one particular class of medicine often get in the way.
Let's be perfectly 100% clear on this. The old concern, especially about morphine, that it could cause the sphincter of audidospasm and worsen pancreatitis, well, that's a ghost from the past. It has been thoroughly debunked in clinical studies. Withholding the right pain medicine because of this outdated fear is just not evidence-based practice, period. Instead, great pain management uses a multimodal approach. Here's how we build a really solid plan. Start with a foundation of scheduled non-opioids. Then use opioids as needed for that breakthrough pain. And for really severe cases, we can even consider adjuncts like low-dose ketamine. Good pain control lets patients breathe deeply, get out of bed, and eat, all things that are absolutely critical for getting better.
Next up is a big procedure, ERCP. This is a classic case where timing is absolutely everything. It can be a life-saving tool when you use it correctly, but it can also cause real harm when it's done for the wrong reason or at the wrong time.
This slide gives you the critical decision-making framework. You should only be ordering an urgent ERCP in two main scenarios. First, if your patient has concurrent acute cholangitis, or second, if they have gallstone pancreatitis with clear ongoing biliary obstruction. For a patient with mild gallstone pancreatitis whose labs are already getting better, ERCP is not the answer.
And this brings us to our final and maybe the most overlooked mistake. The patient's feeling better, their labs look good, they're ready to go home. But our job isn't done until we've answered the why and made a plan to keep this from happening all over again.
This discharge checklist is your key to breaking that cycle of recurrence. For gallstone pancreatitis, the gallbladder has to come out, and ideally during the same hospital stay. For alcohol-related disease, we have to have that conversation and offer real resources. For high triglycerides, we start treatment right away. Don't just write down the cause in the chart, act on it. This is how we prevent the next admission.
So here's the bottom line. Excellence in pancreatics care isn't about some new, expensive piece of technology. It is about mastering the fundamentals. It's about careful resuscitation, early nutrition, good pain control, and fixing the root cause. Getting these 6 things right is the foundation of modern, evidence-based management.
And that leaves us with this final thought. We already have the knowledge to stop many of these patients from getting critically ill. The challenge isn't a lack of evidence. It's consistently applying that evidence at the bedside for every single patient every single time. That's how we solve the pancreatitis paradox. Thanks for joining me.